Namaskar. So welcome to one more session of pharmacology. In this session, I'll be discussing pharmacology questions that came in INI-CET 2020. Myself, Dr. Bharath V.D. I am the Pharmacology Guru. In this session, if you analyze the paper was moderate in case of pharmacology, and most of the questions covered the topics which were covered in the classes. And in this section, the questions are recall based, so there may be a difference in reframing or in the options. Now with that brief background, let me start with the questions. The first question is drug least effective in severe COVID-19 infection is. So as expected, we had done a COVID cure video for you all and we had explained this concept to you. Least effective in severe COVID-19 infection is, the options are low molecular weight heparin, favipiravir, remdesivir and dexamethasone. Now was it taught in the class? Yes, because we had given a COVID cure video for you, and in that I had told you what is mild, what is moderate and what is severe, and what we use in the mild cases is the HCQ, then the favipiravir. Along with that, we can use azithro, doxy, ivermectin. Even though scientific evidence is not there, they are being used. Now favipiravir can be used in mild to moderate cases, but not effective in severe cases. Now moving on to the severe and moderate cases. In moderate COVID-19, we use as remdesivir or you can use HCQ. Anti-inflammatory, we use steroids, and prophylactically we use unfractioned heparin or low molecular weight heparin. We don't use this anticoagulant as a treatment, we use it as a prophylactic. Now in severe, same thing, we use antiviral therapy remdesivir, but it is shown to be less effective in severe cases. So what is in severe case? In severe case, the mortality is very high. Now what is the best drug to decrease mortality? The mortality is decreased by the anti-inflammatory immunomodulator drugs, that is the steroids, particularly the dexamethasone, and one more is the methylprednisolone. Now the recent studies published have mentioned that these steroids decrease mortality in case of severe COVID infection. These are the only group of drugs that have been proven effective. Now anticoagulation, as you all know that we will use anticoagulation in severe COVID, and also tocilizumab, which is an interleukin-6 antagonist, that was also used in severe COVID-19 infection. So if you analyze this very important classification of the users, favipiravir belongs to mild to moderate, but the guidelines given by AIIMS, they preferred using favipiravir in the mild cases. So it is only for mild cases, not for moderate and severe. Now coming to the question, drug least effective in severe COVID-19 infection is, the drug is none other than favipiravir. The drug is favipiravir. That is the drug. The answer is B. Now moving on to the next question. Which of the following statements are false regarding drugs used in the gout? The gout is a very important topic, repeatedly asked. And do we know this concept? Let me read the options. Aspirin is not used as it decreases uric acid secretion. Indomethacin used because it acts by multiple pathways. So first let me analyze whether the first option is right. Aspirin is not used as it decreases uric acid secretion. That's a true statement. Now one NSAID that is particularly contraindicated in gout is aspirin, and I repeatedly told during NSAID class as well as in the gout, because the major problem with aspirin in therapeutic doses, it increases uric acid, that is hyperuricemia. That's why it is not used. Indomethacin used because it acts by multiple pathways. Yes, that is a true statement. Why? Because the indomethacin drug, indomethacin, this drug has multiple, that is it inhibits the enzyme COX. It also decreases the activity of phospholipase A2, and also it decreases the chemotaxis of neutrophils. So it decreases the chemotaxis of neutrophils, and that is the multiple mechanisms. That's the reason we prefer indomethacin in case of acute gout. And if they ask first choice of NSAID in acute gout, will be indomethacin. Moving on to the diclofenac is used as it is concentrated in joint space. Yes, obviously we use diclofenac so for so many painful conditions, and it is shown to get concentrated in synovial fluid, that is in the joint spaces. That is an advantage where it will decrease the pain by acting as anti-inflammatory and analgesic. Now, aspirin is used, it's a false statement, that is the right answer for this. Now, if you don't know B and C, still the answer, you can come across A and D, because one option A is telling it's not used and D option is telling it is used. So obviously, you will know that among these two, the answer would be A or D. So obviously, if you know the concept that aspirin increases uric acid, it is contraindicated in gout. That is the answer. So that is the second question. And moving on to the third. A patient of neurocysticercosis is on anti-epileptic drug. The next step is, now neurocysticercosis, many a times it may present as epilepsy. So patient usually will be put on anti-epileptic drug. Now the best drug of choice for neurocysticercosis is albendazole. Now if you want to add one more drug, plus or minus, you can add a drug called praziquantal while treating this neurocysticercosis. But the problem when you use these drugs, they can increase inflammatory response in the brain. So if the inflammatory response in the brain increases, so it will irritate the brain. There may be seizures, there may be other complications that may occur when you give the drugs which will kill this neurocysticercosis. But we don't want this inflammatory response to occur. That is the reason what we do is, before giving the antiparasitic drug, we want to make sure that we administer corticosteroids and they decrease this inflammatory response. So first you have to give the steroids and then you have to give the drugs. So antiparasitic drug followed by steroid, this is false. Steroids followed by anti-epileptic drug, so this is the best next step. So that is the right answer. Steroids before anti-epileptics, no, because already she is on anti-epileptic. Only anti-epileptics, no need, because you need to treat the cause, that is neurocysticercosis. Only anti-epileptic will not help. So you have to give pharmacotherapy and remove that cyst. So the answer is B, steroids followed by antiparasitic drug. That is the answer. Okay, so moving on to the next question. Which of the following antidepressant has least sexual side effect? The options are fluoxetine, imipramine, mirtazapine, and venlafaxine. So let us write the classes of that. Fluoxetine is an SSRI, and imipramine is a tricyclic antidepressant. Mirtazapine belongs to atypical antidepressants, and venlafaxine is an SNRI. Now, which one has the least sexual side effect? To understand that, now remember that when we use drugs for depression, most of them are implicated in causing sexual dysfunction. And this sexual dysfunction may manifest in variety of forms. One is in erection abnormalities. Second, anorgasmia, and loss of libido. So there are many manifestations. These are commonly seen. Now, whenever you are increasing the serotonin in the body, particularly in the CNS, it is known to interact with a receptor called 5-HT2, and that is going to increase the sexual dysfunction. The excess of serotonin is the culprit, and if it activates 5-HT2, the sexual side effect is going to increase. So what are the drugs which increase this? One is the SSRI, and then SNRI. So more, I'm giving this so that you can understand that in a better manner. So SSRIs increase it more than SNRI than DCS. Because of this sexual problem, so there came one more drug called mirtazapine. Mirtazapine, what is the advantage? Mirtazapine is also called as NASA, NASA. Now it is called noradrenergic and specific serotonergic antagonist. It is called noradrenergic and specific serotonergic antagonist. So what it will do, suppose we are having two neurons, one is the noradrenergic neuron and one more is the serotonergic neuron. There are two neurons like that. Now there are alpha 2 receptor on both. If they are present in the same, then they are called auto. If they are present in the opposite, that is in the serotonin neuron, we call it as heteroreceptor. Now when you block this by giving mirtazapine, when you block this, it increases noradrenaline here and serotonin here. So this serotonin will mainly act on 5-HT1 and this is responsible for the antidepressant activity. This is responsible for antidepressant activity of mirtazapine because it particularly acts on 5-HT1. Now other specialty of mirtazapine is it blocks 5-HT2. It is a 5-HT2 blocker and second, it is also a blocker of 5-HT3. So this is why it is blocking 5-HT2. Now 5-HT2 activation is the one which is responsible for sexual dysfunction. Now we are blocking this. So that's the reason mirtazapine, which is also called as NASA, has less sexual side effect. Comparing with that, we have a atypical antipsychotic that is called bupropion. Bupropion is called NDRI, which is used as the anti-smoking drug. It increases noradrenaline and dopamine, and it also has less sexual dysfunction. But the problem is it increases anxiety. It is a stimulant, so it is not used in anxiety disorder. But it is used mainly for smoking cessation. And one more specialty of mirtazapine I need to add here is it also blocks histamine receptor, so it induces sedation. So that's an advantage if the person is having depression and he wants to sleep, is having insomnia, then the better drug is to add mirtazapine. Now moving back to the question, which of the following antidepressant has least sexual side effect? Obviously the maximum is with fluoxetine, next venlafaxine and imipramine. So least or less is with mirtazapine. Next time they may add up bupropion. So that is the answer for this fourth question. Moving on to the drugs, fifth MCQ. Bone forming drug among the following is. This is a repeatedly asked question. It's not a new question. It came in NEET exam. Now bone forming drug among the following is, remember there are two varieties in osteoporosis treatment, bone forming and inhibiting bone resorption. So bone forming drugs, they stimulate osteoblasts, and bone resorbing inhibitors, they inhibit osteoblasts. So which are the drugs which stimulate this osteoblast? They are nothing but the parathormone derivative, that is teriparatide. A newer drug in this category is abolaparatide. These are all the parathormone derivatives, and one more is an inhibitor of a protein called sclerostin. So please add up this to your notes. An inhibitor of sclerostin, and the drug is called romosozumab. So it inhibits a protein called sclerostin, which is required for bone metabolism, and even this drug is known to increase bone formation. And any other drug, rest of all the drugs which you study in osteoporosis treatment, they all inhibit bone resorption or inhibit osteoclast. Sometime back, 10 years ago, we had a drug called strontium ranelate, which is not in textbooks nowadays, but I don't know. If the examiner asks, we cannot go and question them. So it is the one which can stimulate both bone formation and bone resorption. It will stimulate bone formation and inhibits bone resorption. So the question has been asked, bone forming drug among the following is option B, teriparatide. Now all the other options, bisphosphonates, calcitonin, roloxifene, they are all inhibitor of bone resorption, or they inhibit the function of osteoblast. The answer is B. Now this one, sixth, patient prescribed with tricyclic antidepressant for depressive disorder, that is episode, and stayed in hospital for 4 weeks and improved. What is the main concern after discharging this patient? The options are increased suicide risk, arrhythmia and ECG monitoring, have to do therapeutic drug monitoring, sedation as a side effect. Now analyzing each and every options here, increased suicidal risk. Yes, the increased suicidal risk if the age is less than 25 years or equivalent, and that is what the studies tell. If the patient's age is 24 or less, then the increase in suicide risk is more. And this patient has improved, so there is no question of suicide, and that's not a worry for us. Second, arrhythmia and ECG monitoring. Yes, that's the problem. Now, whenever we start a patient on TCAs, the major concern what the physicians will have is that this have narrow therapeutic index. So even if you give low dose or if you give a bit of high dose, the problem is the drug will increase. So that will lead to toxicity. Now this toxicity is an issue. It will manifest, one is as CVS and CNS. Now in CVS, it may manifest as QT prolongation, and that may progress to arrhythmias. So this may progress to arrhythmias. Second, in CNS, it may progress to seizures if the toxicity is more. And this is the one which you have to monitor when you discharge the patient for toxicity, and tell the patient if the toxic symptoms appear to come back to the hospital, because the drug is very narrow therapeutic index drug. That's the reason these are not the drugs which we start for depression, start with the SSRIs. Now, if the toxicity develops, what are the questions we expect here? For arrhythmia, what we use is lignocaine. And for seizures, what we use is benzodiazepines. And tricyclic antidepressant toxicity, we also use sodium bicarbonate. Now, why sodium bicarbonate? It's a general pharmacology. Sodium bicarbonate makes the pH of the blood alkaline. So this drug at alkaline pH becomes more and more ionized. If it is more and more ionized, it cannot work in that alkaline medium. So that is one thing. Have to do therapeutic drug monitoring. Yes, it's a narrow therapeutic index drug, and you have to do therapeutic drug monitoring for that. That is not a main concern. Because when the initiation was done, after 3 to 4 weeks, we would have done the TDM of this drug and then discharge. So that's not a major issue. Sedation and side effect. Now remember, tricyclic antidepressants, they also block muscarinic receptor, which will cause dry mouth, blurring of vision. They also block the histamine, which is known to cause sedation. They also block alpha receptor, which is known to cause hypotension. The anticholinergic side effect is a problem which will cause the dry mouth, then blurring of vision, constipation, and urine retention, and also that is responsible for the cardio complications. The main concern when you discharge this patient on TCS is because of narrow therapeutic index and the toxicity. And recently, I got a call from one of the patient. She had swallowed 10 tablets of amitriptyline. So that is the reason. Many a times they may take it to commit suicide also. But the risk is, this is a narrow therapeutic index. And I told you, they have not mentioned the age here. And that's why that cannot be taken as an answer. So the answer is arrhythmia and ECG monitoring. Now moving on to the seventh one, which of the following statements are true? So let us see what are the statements which are true. The morphine is used in pulmonary edema. Obviously, yes, it's a true statement. Why? Because morphine Morphine is used in pulmonary edema because morphine shifts the blood from pulmonary circulation to systemic circulation. So thereby, if it shifts the blood from pulmonary, that is lungs, to systemic circulation, that means it is going to decrease the edema. What do you mean by shifting from pulmonary to systemic circulation? That means it will dilate the veins. If you dilate the veins, what happens? The blood remains in the peripheral pool, that is in the veins. So it will not come to the heart and it will not go to the lungs. So that is the meaning of shifting of the blood from pulmonary to systemic circulation. And the same reason, this morphine is also used for myocardial infarction. Now it is not only for pain, it decreases the air hunger. Now when does the air hunger occurs? When there is pulmonary edema. So it reduces the pulmonary edema and reduces the air hunger. That's the reason. Second, it also decreases the sympathetic outflow. Morphine also decreases sympathetic outflow in case of MI. And that is also crucial when there is anxiety due to myocardial infarction. So that is a true statement. Now coming to the second statement, pethidine is used in biliary colic. Now please note down, pethidine is a derivative of atropine. That means it has anticholinergic property. So anticholinergic drugs, what they do, they are used in colicky abdominal pains. They relax this spasm of biliary sphincter, and that's the reason we can use pethidine in biliary colic. But note down, this is very important, twice asked, morphine should not be used in biliary colic. It is contraindicated in biliary colic. So these are the two contrast things you have to remember about morphine and pethidine. So morphine is contraindicated in biliary colic. That was one MCQ asked. Now they are telling pethidine is used in biliary colic, which is a true statement. Because why? It has anticholinergic property. Indomethacin is used in headache. Yes, because it has multiple mechanisms. And many students tell that, sir, it itself causes a headache. Yes, this main idea is frontal headache, severe frontal headache. But that is not seen with all of the people whom we administer the drug, only in few individuals. But we can use that in headache, no issues. But remember, the most important sentence to read, aspirin used in peptic ulcer disease. Who will use aspirin peptic ulcer disease? Aspirin itself will cause gastric ulcer, then who will use it? So obviously that statement is a false statement. All other statements are true. So A, B, C, so as your question paper options were that A, B, C only are correct. A, B, C only are correct. So that is the right answer. So that is about the 7th question. Moving on to the next 8th question. Mechanism of anti-migraine drug causing angina-like symptoms. Now what are the anti-migraine drugs we use? One is the sumatriptan, that is triptans. So they are sumatriptan or any triptan. The main mechanism of action is they are 5-HT 1B 1D agonist. What do? They cause vasoconstriction, particularly extracranial blood vessels, and thereby they decrease headache. Similarly, ergots also have serotonergic property. They also cause vasoconstriction. Now they have not mentioned what is the drug used for migraine. Let us see the options. Now releases nitric oxide will not cause angina-like symptom because the nitric oxide is going to cause vasodilation, so that will not increase angina. Inactivates calcium channel. It doesn't need to be specified. The drug which inactivates particularly T type of calcium channel is a drug which we use for migraine prophylaxis, that is called flunarizine. The drug name is flunarizine, which is used for migraine prophylaxis. We can also use verapamil also in case of migraine prophylaxis, which inactivates calcium channel. Now 5-HT antagonism is not an issue, but the angina symptoms are increased by 5-HT agonism. I told you 5-HT 1B 1D agonism is the one which is causing vasoconstriction. Now if you have vasoconstriction, what happens? The angina symptoms increases. What is angina? Angina pectoris, which is nothing but spasm or the blockade of blood vessels, which will increase the chest pain. So if the drug is causing vasoconstriction, obviously it will increase the anginal symptoms. So the answer for this question is C, 5-HT agonist. Moving on to the ninth question, antimicrobial related, match the following type of question. So here they have asked meropenem, vancomycin, metronidazole, ceftriaxone, and organism MRSA, bacteroids, Klebsiella pneumonia, and H. influenza. Now, first and foremost, let us solve what is easier. Vancomycin, as you all know, that it is effective on positive only, and that is considered the drug of choice for MRSA. So we have matched B1. Now next one is the metronidazole. As you all know that metronidazole is highly effective in anaerobic infection. So we use metronidazole in case of bacteroid. Now the confusion is between meropenem and ceftriaxone. Because ceftriaxone you can use it in both Klebsiella as well as H. influenza. But the examiner is brilliant here because he wants you to know that these Klebsiella are nowadays highly resistant. That is, they have started producing extended spectrum beta-lactamase. Now, how the questions change as the year change. In 2019, they had asked this question: what is the drug of choice for ESBL producing Klebsiella? And for ESBL producing Klebsiella, the drugs which are called drug of choice are carbapenems. The drug of choice are carbapenems. So the examiner wants to denote that we already are facing the issue with Klebsiella, that is producing ESBL, extended spectrum beta-lactamase. Now, for this, the ceftriaxones are not effective. For them, you have to add up with either clavulanic acid. The main thing, what we can do for them, if the carbapenems are not there in the option, you can use amox plus clavulanic acid, or you can add up piperacillin plus tazobactam. This can be added, but they are not in the option. Now, what is the answer for that? For meropenem, it is the Klebsiella pneumonia, which is extended spectrum beta-lactamase producing bacteria. What we left out is, let me write this option, A, it is 3, and the last one is D, so no need to worry, it is the ceftriaxone which is used in H. influenza. Most of the gram-negative infections, what we use commonly nowadays is the drug ceftriaxone. So this is the answer for this question. Okay, all the following drugs worsen myasthenia gravis except. Now, lidocaine, diazine, phenytoin, meropenem. So many are there in the option. So what I tell is they should not give a brand name, diazine. Even if it is so much popular, examiner, they should have given at least what are the constituents of that. We don't recommend students to remember the constituents of this diazine. Mainly diazine consists of magnesium hydroxide and aluminum hydroxide. So it contains mainly the magnesium hydroxide plus aluminum hydroxide. These two combinations are present in diazine. Now this is a memory based question. There is no logic in answering this. If you remember the table given in Harrison, you can answer this. Now I have chosen certain important drugs because it's all memory based. If you have finished reading everything and if you have time, then you can by heart this. Otherwise, this is one of the questions to be skipped and read other things. And if you have read all the things, then you can come back to this table. Now coming to the drugs, antimicrobials, particularly the fluoroquinolones like ciprofloxacin or moxie, they can increase the risk of myasthenia gravis. Then aminoglycosides, particularly these are very important, which you already know because aminoglycosides, the main adverse reaction is neuromuscular blockade. So if you are using in myasthenia gravis, obviously they will increase the myasthenia gravis. For example, gentamicin. So other ones, macrolides like erythromycin, azithromycin, clarithromycin. Now neuromuscular blockers, particularly the non-depolarizing, it is competitive neuromuscular blockers. Then local anesthetics like lidocaine or lignocaine. Even the magnesium, note down, the magnesium can decrease acetylcholine release from the nerve terminal. So that is a mechanism. Then quinidine, procainamide, beta blockers, the chloroquine derivatives, that is HCQ, chloroquine, botulinum toxin, obviously you know that. Botulinum toxin decreases acetylcholine release. Obviously in myasthenia gravis it's not that much. And anti-epileptic drug phenytoin. So very complicated to remember. If you have time, remember, otherwise you can skip this question, because in any exam, the examiner has to make at least one question tougher or memory based, otherwise everybody will score. So that is one type of question. So in coming to this, after reviewing the table, what we use, lidocaine should not be used. Digoxin, because it consists of magnesium, then phenytoin, it increases myasthenia gravis. Now one antibiotic you can safely use is meropenem. So all worsens myasthenia gravis. It's an exception question. The answer is meropenem. So you can use meropenem but not the other things. Okay, so this is once again a repeated known concept. It's not new. Only thing is students got confused. That's it. A patient was prescribed high dose penicillin. Now what is the confusion? As soon as you read high dose, their thinking went away. Along with gentamicin for his symptoms, which of the following statement is true? TDM is done for penicillin, done for gentamicin, for both TDM not to be done. And few students, that option was here. One more option, that is penicillin TDM is done because it causes anaphylaxis. Now basically you should understand that we do therapeutic drug monitoring only if the drug is narrow therapeutic index and the drug concentration should correlate with the clinical response to measure the compliance of the drug, right? High inter-individual pharmacokinetic variability, then we will do that. And we had given a mnemonic for that. Whenever you need to do TDM, what are the list of drugs? I had given the mnemonic, look at TDM concentration. So this is what I gave. So L stands for the lithium, and A stands for aminoglycosides and anti-epileptics. And T is theophylline, and TC is as well as an anti-cancer drug or immunosuppressant. The immunosuppressant tacrolimus, digoxin, an anti-cancer drug, that is methotrexate, and one more is cyclosporin, which is a immunosuppressant. These drugs require therapeutic drug monitoring, right? So coming back to the question, gentamicin is a aminoglycoside, and particularly in renal failure it will be a dangerous drug because the elimination is in the kidneys. And we do therapeutic drug monitoring for that. So penicillin, as it causes anaphylaxis, whether you give high dose of penicillin or mild dose of penicillin, that will not have anything to do with anaphylaxis. Even if you give small quantity, it will lead to anaphylaxis. That's why before administering the drug, we give a test dose, then we give. Now, what is the drug of choice for anaphylactic shock? You all know that is adrenaline IM 1 in 1000, 0.3 to 0.5 milligram into the vastus lateralis. That is the answer. Now, I know why you got confused because of the high dose. Now, in other foreign countries, they do therapeutic drug monitoring for penicillin also, but not in our country. The problem when you do TDM, therapeutic drug monitoring, is a cost factor. The cost factor has to be borne by the patient, and we use a machine called HPLC, high performance liquid chromatography. I think this question was also asked, what is the device used to measure the drug concentration for TDM, that is HPLC. And when I was doing post graduation, this HPLC was a 5 marks question, and that is usually seen in central institute. So in central institute like AIIMS, JIPMER and all, there they do this TDM, and if you are not from that institute, you don't know what is TDM, what they are doing in HPLC. Even if you are in central institutes, if you have not observed this, you will not answer these things, particularly the HPLC question. Now, why it is becoming a trend, TDM? Everywhere you see from last 2-3 years, the TDM is coming into the questions because this is the trend. You need to monitor the drug concentration to check whether it is working, whether there is toxicity. And TDM is one of the future topics that will be asked in the pharmacology or as an integrated topic, right? So answer for this question is TDM must be done for gentamicin. That is the answer. Match the drug and antidotes combination. Now, many a times even in last minute revision programs, we give a list for you with all the drugs and antidotes. Take some time to revise them. So let me clear it very fast. Heparin, you all know that the antidote for heparin is protamine sulfate. For one, it is the B. Now, second, it is ethylene glycol. The antidote is fomepizole. Not only for this, fomepizole is antidote for ethanol and methanol toxicity. And you don't know hydrofluoric acid, leave it. But do you know what about valproate? Valproate causes hyperammonemia. If it induces this because of toxicity, the drug which is used as antidote is levocarnitine. So 4, it is A. And even if you don't know what is hydrofluoric acid, it's an acid used in industrial workers. It will cause blisters and everything. It can be taken inside also in case of poisoning. But what happens here is the fluoride, that is hydrofluoric acid, fluoride will cause severe electrolyte problems, electrolyte abnormalities. So the major electrolyte abnormality should be corrected. So what we use as an antidote is calcium gluconate in hydrofluoric acid toxicity. So for this, it is D. It's a direct forward question and there is no logic into applying that, and it's a must know question. Even if you know 3, 1 you can do without knowing, right? This is how it can be done. 14th question, disulfiram mechanism of action. Now it's an anti-craving agent. Now first and foremost, remember that what was disulfiram called as? Disulfiram, the other name for disulfiram is antabuse. That means it is used to decrease the abuse liability of this drug, right? So where do we use this drug? It is used in only highly motivated individuals. Why highly motivated people? Why highly motivated people to quit alcohol? Because you all know that the ethanol will give rise to acetaldehyde, and acetaldehyde is going to give rise to acetic acid. Now this acetaldehyde is the one culprit. When it increases in the body, it is known to cause nausea, vomiting, all this discomfort in the chest, and even if it is high, it will cause respiratory depression and also severe headache. So this is the problem. Now these conversions are done by, this is done by alcohol dehydrogenase, and this is done by aldehyde dehydrogenase. Now this enzyme is inhibited by disulfiram. Now disulfiram inhibits this enzyme in such a way that it is irreversible. The inhibition is irreversible. That means it requires the fresh enzyme to synthesize. Now when the person takes alcohol and he takes disulfiram and starts drinking alcohol, its effect will last for 1 to 4 hours. And it will peak around 12 hours. So it will acquire, if you are giving the drug repeatedly, it will peak around 12 hours, but the disulfiram reaction will be immediately seen from 1 hour to 4 hours as soon as you start drinking alcohol. Now, when the patient drinks alcohol, he will experience this nausea, vomiting, discomfort, and headache, then respiratory depression. Then who wants to drink alcohol? They try to stop taking alcohol. So first option is it's an anti-craving agent. No, it will not decrease craving in alcohol. The anti-craving drugs which are known to decrease is naltrexone, ondansetron, then topiramate. Okay, and one more is acamprosate. So these are the drugs which are known to decrease the craving in alcohol. Second one is, should be used in patient who has mild motivation to withdraw. No, if they have strong motivation, because if they are not having motivation to quit alcohol and you give them disulfiram, they will go after a few days and they start drinking and they will end up in casualty with these problems. So that is a false statement. This is a false statement. Taking disulfiram and alcohol, patient feel drowsy, discomfort, respiratory depression. Yes, this is a true statement, obviously. And it's not a complicated question to answer. If you know what is disulfiram, why people drink, and when they take disulfiram, what happens, then this will be the right answer. By inhibiting alcohol dehydrogenase, that's a false statement because it acts by inhibiting aldehyde dehydrogenase. So the answer is C. So here the question starts with disulfiram mechanism of action. I think the question would have been, which of the following is the true statement? Now, since it's an irreversible action, now when you stop disulfiram today, patient is taking disulfiram from weeks together, and if you stop disulfiram today, it can work for 7 to 10 days. Why it will work for 7 to 10 days? Because it inhibits this enzyme irreversible. And the body has to synthesize a fresh enzyme to metabolize the alcohols. That's why the duration of action can extend up to 7 to 10 days. Okay, so in the comment section, you can comment whatever the other option was present in the question. I am not getting that. Accordingly, I can answer these things. Okay, so nowadays, see, particularly the Central Institute, they are also asking the devices. Are these devices new? No, they are old. They are being used from so many years. This device is called PMDI. What is PMDI? It is pressurized meter dose inhaler. That means it consists of a canister and is the mouthpiece. Now through this, the drug is sprayed. Now we have to shake well before use, then hold it in the mouth, and then we spray. Take deep breath and hold it for 10 seconds. Now the problem is, when you use this meter dose inhaler, when you spray it, the drug is sprayed directly into the oropharynx. When it directly sprayed onto the oropharynx, what is the problem? The problem is, if the particle size is very, very large, it is tend to get deposited in the oropharynx. If it is a steroid which you are spraying, it is known to cause oropharyngeal candidiasis. First one, how to avoid that? Do gargling. Second, if there is oral candidiasis, treat with the drug like topical clotrimazole, or you can treat with nystatin. Now let me read the options. Portability, it's not a drawback. It's not a drawback. You can take it everywhere. Does not provide instant relief. It's not a drawback because it produces instant relief. It will be inhaled and you will get instant relief. Drug deposited in oropharynx, that is the drawback. So this is the answer for this question. C. Must be administered in hospital setting. No, you can take it anywhere. You can administer in the house, whenever you are traveling, you can take it anywhere. So the only drawback is it is getting deposited in the oropharynx. Now how to avoid this? What is the next level of question we expect? To avoid this, we have something called a spacer. So you can see that this is the spacer diagram which is there here. And it has a body, valve, mouthpiece. And this is where we put the inhaler. So inhaler adapter is there. So we'll put the inhaler here. If you see this image here, the person is putting the mouthpiece here and the inhaler is here. Now when it is being sprayed, what happens? The drug particles are in this spacer. And whatever the larger particles are there, if the larger particles are there, they will get trapped in the spacer only. So only the small particles enters inside, and without getting deposited in the oropharynx, they will enter the lung. So that is the advantage of spacer. The advantage of spacer, it will not allow the drugs particle deposit in the oropharynx. So, and also the advantage of spacer is in elderly and children who doesn't have good coordination of breath. Using a metered dose inhaler, you need to have good coordination of the breathing, but for this it is not required. Now I have made a list. What are the advantages? The spacer allows large volume to reach the airways, that is fine. Minimal deposition in the mouth or throat. Hoarseness of voice or deepening of voice or candidiasis is not in. Why? Because the drug is not getting deposited locally. It is down direct to the lung. So that is the advantage of spacer. I don't know this spacer was also asked or not. That's why I am covering this in this discussion also. Moving on to the next question. Which of the following drugs will not produce fixed dilated pupils? So remember, the dilation of pupil is what we call it as mydriasis, and the constriction, which is opposite, is what we call it as meiosis. This is what we call it as meiosis. Now, who will produce mydriasis? One is if the drug is sympathomimetic, or it can produce by anticholinergics. Who can produce meiosis? Meiosis can be produced by an alpha blocker or mainly by cholinergics. So in the question they are asking, dilated, which drug causes dilated pupil? So either it should be sympathomimetic or anticholinergic. So anticholinergics, you all know that they cause passive mydriasis, and alpha blockers cause passive meiosis. So let us analyze the options. Cocaine. Now cocaine, the main mechanism of action is it inhibits the uptake of noradrenaline into the presynapse. So it increases the sympathetic activity. So obviously it will cause dilation of pupil, and among local anesthetic, this is the only one which causes dilation of pupil. Pilocarpine is parasympathetic, that is cholinergic in nature, and this is the one which causes meiosis. Phenylephrine increases activity, that is sympathetic activity, because it acts on alpha 1. Amphetamine is an indirect sympathomimetic, so obviously it also increases the activity of sympathetic. So the drug which doesn't produce the dilation of pupil is pilocarpine. Pilocarpine. There is no confusion in that. Pilocarpine is a cholinergic drug which causes meiosis. It's a direct question, no confusion. Yes, the favorite for the AIIMS people, adrenaline. Adrenaline is one of the favorite for the AIIMS people. So that's why first time, every time 2-3 exam they asked adrenaline graph, then they asked adrenaline anaphylactic shock. Now they are asked dilutions of epinephrine. They got bored with the anaphylactic shock dose, the dilution. So now they are asked IM in anaphylaxis, IV in cardiac arrest with lignocaine. This has also been extensively covered in the class. Now remember the dosage, that is option A, anaphylaxis, it is 1 in 1000, which is given IM. In cardiac arrest or IV, what we use is 1 in 10,000 dilution. And with any local anesthetic, the dilution is from 1 in 80,000 to 1 in 2 lakh. So this is the dilution used for adrenaline. So they have correctly matched this. I don't know how the options were given. This is the right answer. For IM, it is 1 in 1000. 1 in 1000. Even for subcutaneous, it is 1 in 1000. Even for inhalation, it is 1 in 1000. 1 in 10,000 is for the IV, the intraosseous, and intracardiac. 1 in 1 lakh is for the lignocaine, that is local anesthetic. Straightforward question. Okay, so this I have already explained to you all. Drug that reduces mortality in COVID-19 patients. Now we don't use this in severe case favipiravir. Low molecular weight heparin is highly helpful when they are increased D-dimer levels. Chances of coagulation is common, then it is very much helpful. Remdesivir, I told you, it is very much less effective in severe cases, in severe COVID. So mortality wise, it will not decrease that much. And they have done a study where they have used steroid, and steroids are the one which are known to decrease mortality in COVID-19 patients. Right? 2 questions from COVID. So the COVID cure would have helped you in a much larger way. So the dexamethasone is a steroid which is known to reduce mortality in COVID patients. Moving on to this question. If codeine is coming to the market in combination with dextromethorphan as antitussive, this combination should not be used as it is irrational, can be used to treat cough effectively, can be used as it is having different mechanism of action, should not be used due to addiction. Now, this combination, why it is irrational, why it is addictive, why it is effective, you will understand that. To understand that, you should understand this simple pharmacology. Now, codeine was there in the market already. Codeine was already there in the market. Now, codeine acts on mu receptor, and by acting on mu receptor, it decreases the cough reflex. The problem with codeine is when you use that, it causes constipation, and also it increases the abuse liability of this drug. Abuse. And also, this is not used in children because it may cause respiratory depression. It may cause respiratory depression because it is acting on mu. The major action is on mu. So the scientist wanted a drug which will not do these problems to a patient when we give it for cough. So what they did is they took metformin. Metformin was obtained from codeine only, and they took the dextroisomer of that is called dextromethorphan. Now the dextromethorphan, the mechanism is it is an NMDA antagonist. NMDA antagonist, and because it doesn't block mu, it has less chances of constipation or no. Next, it has less abuse liability and less respiratory depression, very least or no. Now the purpose of discovering this dextromethorphan, why is we never wanted these adverse drug reactions. Now if somebody comes to you and tell that you combine both of them together and give to the patient, what is the use in discovering dextromethorphan? So this combination is irrational. This combination is irrational. What is the use in combining them together? We discovered a drug dextromethorphan to combat certain side effects. Now when you give codeine with that, the patient obviously will have respiratory depression, he will have the constipation and addiction liability. So that's the reason this codeine comes under Schedule H. That means without prescription, the codeine is not given at all, because the high addiction, because in the body codeine will become morphine, which is highly addictive. But the addiction liability of metformin, that is dextromethorphan, is very less. So coming to the options, should not be used as it is irrational is the right answer. Now what about the other? Can be used to treat cough effectively. Even though you know that it is highly effective, see, both are equally effective. That is what the studies have shown. Even if you use codeine, that is highly effective, but the problem is constipation, respiratory depression. Why to combine one more? Can be used it as different mechanism of action. It doesn't mean that if they have different mechanism, you have to combine and give burden to the patient. Should not be used due to addiction. That is also one of the reasons. But the major reason is it is irrational, because these are the 3 important things why we should not combine them together. So the better option is option A. A patient with pelvic fracture and head trauma with CT suggestive of intracranial tension was given morphine for pain and respiratory difficulty he was given morphine for pain, and after that respiratory difficulty was seen. What could be the cause? Now, this is a repeatedly asked question. We are telling that patient having pelvic fracture head trauma, any head injury case, any head injury, you should not use opioids like morphine. Now, why morphine should not be used? It's a respiratory depressant. Now, if it is a respiratory depressant, what happens? It increases carbon dioxide and thereby it increases intracranial tension, which is already there. And also it causes meiosis. Morphine causes meiosis, and it's very difficult to assess the progression of head injury. This is a repeatedly asked question. Morphine should never be used in head injury because of these problems. Now coming to the options, due to morphine addiction. They are not given he is a morphine addict, and because of this drug he will not become morphine addict because of the therapeutic dose. Could not breathe due to pelvic fracture. That is not the reason. Respiratory depression and carbon dioxide retention due to opioid, that is the right answer, and that is the logic, and that has been taught in your UG days also. It's not a newer concept for you. Due to CNS lesion, the history is not telling any CNS lesions. History is not telling that he has some ear embolism that is going to pulmonary and causing this problem. That is not given. So the answer is C. This is the answer for this. Okay, coming to the epilepsy question. Absence seizure case was given. Which drugs are effective in this case? Now moving on to the absence seizure. Absence seizure mainly seen in children's. It will have 3-hertz spike wave pattern. And the drugs which are effective in absence seizures are, one is the valproate, lamotrigine, and ethosuximide. These are highly effective drugs for treating the absence seizure, and that has been told in the class also. In the options, we have 2 drugs, that is valproate and ethosuximide. Now, certain anti-seizure medicines, they are contraindicated in absence seizure. One is carbamazepine, that is known to increase the absence seizure. Second is phenytoin, then vigabatrin and ticagrelor. These drugs are known to increase the seizures. The cause is unknown. But the drugs which are used are, so any of you already know in your class that valproate and ethosuximide are used. Now the advantage is they also block T type of calcium channel in the brain, and that's the reason they can be used in absence seizures. So the answer for this question is 2 and 3 only. That is option C. Option C. Okay, the last question. 15-year-old female complains of cough and sore throat. She was prescribed an antibiotic, following which she came back with the symptom. Which drug would have caused it? Now, we have the options like fexofenadine, salbutamol, amoxicillin, and corticosteroids. Obviously, they have asked in the question that is an antibiotic. A drug which causes hypersensitivity reaction, that is rashes, is amoxicillin. It's a penicillin group of drug. The main problem what we expect from them is allergy. So many a times we use fexofenadine for treatment of allergy, so that cannot be answer for this question. Salbutamol is a beta-2 agonist, and that is used for the asthma, any acute attacks of asthma, and also for hyperkalemia treatment. Corticosteroids are once again used in the treatment of allergy. They themselves will not cause allergy. So it's a direct question. They are given an image with the rash. Answer is amoxicillin. Okay, so we have come to the end of the discussion, and we have covered 21 questions. And I don't know, one more question was there. Was there a question asking the steps in giving IM injection? I don't know, because no student commented on that. If that is there, please comment in the below tabulations which you have. This is what the questions were. Now, if you analyze this paper, maybe the paper, when you see, it looks like complicated, but most of the options were known and being taught in the class. So don't worry, if you have got a good rank in INI-CET, then all the best. If you are in the range of mid-range where you got the rank but you are not getting any clinical seat and you are getting depressed, don't worry. You have a huge exam coming in March and April, which is going to glorify you. So keep your focus on that exam. Keep your revisions going on. Revisions are the key at this point. Solve more and more MCQs, revise more and more, and that's it for now. Thank you all, and expecting the comments below in the YouTube channel. Thank you.